Good morning, everyone. If you could take your seats. Thank you so much for coming. This is our third, hard to believe, our third PPS reporting DSRIP kind of outreach. So we're delighted to have you here. Thank you so much. And again, we have folks from the Millennium Collaborative Care PPS and community partners. Ann Monroe, from the President and CEO of the Health Foundation for Central New York, and I'm John Craik from the P2 Collaborative. And we're sponsoring the event and running the event. And actually, I say that I realize that now the PPSs are paying for this. So thank you for the PPSs for convening us. The hard work of convening, though, really falls on Ann's staff and my staff. So I'd like to thank Tara Maving, Katie Cosmerl, Kate McLaughlin, and I think Steve Crops was involved as well. So thanks to our staff for putting all of this together. And if it runs smoothly, it's because there's a lot of hard work that takes place ahead of time. Quick show of hands. How many of you have been to these in the past? Just want to get a sense of how many newbies are. Okay, that's good. So how many of you are here for the first time? All right, so we've got a nice mix. So if you're here for the first time, kind of what our little spiel is, the way this thing usually works is I do some very, very quick opening comments, usually run through a fairly corny little exercise that we do. Hopefully it has a little bit of a point too. So we're not going to depart from that kind of schedule, and then Ann will facilitate the questions and answers afterwards. Speaking of that, there are cards on your table. If you have any questions for any of our panel presenters, please write the questions on the cards. We will pick those up, and then Ann will facilitate the Q&A after the presentations. But first, I kind of wanted to kind of put this work in a little bit of perspective. And several months ago, I was talking to somebody actually at an airport bar, and we were just chit-chatting about what we do. And as I started explaining DSRIP and PPS, he was very, very interested in this work. And then I mentioned, kind of as a matter of factly, that the PPSs are really focusing on the Medicaid population. And he was aghast. He said, why is all this money being spent, and why is it all being focused specifically for the Medicaid population when there are real, honest, hardworking Americans and middle-class people suffer from health care and health systems issues as well? Why are we spending billions of dollars on Medicaid people? And I fumbled around with an answer and talked a little bit about moral and ethical issues and how many Medicaid patients there were in Western New York, and was completely not satisfied with the answer I gave. And as always happens, 2 or 3 weeks later, the answer hit me. And the answer hit me because I was at a conference with somebody who led us through an exercise, which we're about to do, which really, really drove the point home for me. So I'm going to do that. You ever go to these conferences and somebody does something and you think, man, that's so great, I can't wait to try that? And then you do it and hopefully it works as well as the other person did. So we're going to give this a shot. Real quick question. So one word I want to focus on. This gentleman said everybody should be treated equally, all right? And he kept saying that equally. So I just want you to keep that word equally in the back of your mind while we do this. So quick show of hands. How many people here have been to a Bills game? Yeah, that's about what I figured. All right, just women now. How many women here have been to a Bills game? All right, yeah, good. Buffalo's so great this way. When you go to a Bills game, one of the things that I've been told is that there are as many men's restrooms as there are women's. People are going, you know where this is going, right? All right, so there are just as many men's restrooms as women's restrooms. So in theory, the capacity for the men and the capacity for the women are the same. In other words, they're getting treated equally, right? What are the lines like comparatively for the men's and the women's room, right? Do we even have to answer that? Now, this gentleman went through this wonderful exercise and talked about the difference between treating people equally and equitably is giving people what they need to bring everybody to the same level. So if Rich Stadium, or I'm sorry, New Era Field, right? If New Era Field was going to treat people equitably, there would be more restrooms and better capacity for the women who are attending. Now, this is interesting, right? It seems really, really cool. You help the most vulnerable, and there's a real strong argument. In fact, according to the speaker, there's a whole body of literature, a kind of this canary in the coal mine kind of literature, saying that if you help the most vulnerable, everybody benefits. Now, gentlemen, if you go to the Bills games with your date, your wife, your sister, your girlfriend, whoever, what are you doing while she's waiting in line for the women's room? You're waiting for her, right? Right, so it's a hassle So the men who have the benefit of the quicker restrooms, we end up waiting for the women because they're not treated equitably, which is, I thought, was a real interesting illustration. So in healthcare, if the most vulnerable of us are treated equitably, if they're getting better access to service, if they're getting better service, more community-oriented service, if they're frankly healthier, that helps everybody, not just them. So it makes sense for everybody, not just the poorest, not just the people on Medicaid, but it makes sense for the entire community, the entire society, to treat people equitably. So with that in mind, we're going to turn it over to our friends from the PPSs, and we have from my right to left, Dr. Anthony Billatier from Millennium Collaborative Care, Chief Medical Officer, Al Hammonds, the Executive Director of the Millennium Collaborative Care. The empty microphone is Dr. Carlos Santos, who is still a practicing doctor, which means he's on call, and he's been called into surgery. So Amy White-Storfer, who's the Executive Director of Community Partners of Western New York, will be presenting for Community Partners. One last plug, P2 has 2 events coming up, one on September 17th. Each of the PPSs are sponsoring this. It's around helping doctors discuss and address palliative care and end-of-life planning. So we hope you'll help get the word out. I know Amy's going to talk about that a little bit, so we're grateful for everything the PPSs do. We're grateful for all of you for being here, and look forward to the Q&A after the presentations.
Well, I had all these notes, and then John set the bar so high by talking about bars and bathrooms that I guess I'll throw those notes out and just... But I will tell you a quick story about an airport bar, because it's amazing what happens at them. I was sitting at the JFK bar waiting for a plane. I was with Dan Pareca, and he knows that, and forgive me, but that having grown up in northern Wisconsin, that I'm a Green Bay Packer fan, and I'm an own a share in the Packers. And we were talking about that, and suddenly from down the bar, this woman goes, "I'm an owner too." And it turned out, and then from the end of the bar, this guy goes, "I am too." And at this JFK bar, we had 3 owners of the Green Bay Packers, which would pale compared to what would have happened at that bar at the Buffalo airport, I know. So just a few comments before I turn it over to Amy. We are currently in DSRIP in year 2, quarter 2. And this is a 5-year program. So if you do your math, we're getting close to the midpoint. And what we're seeing across the PPSs, from my seat as co-chair of the oversight panel for DSRIP, is we're starting to see the bell curve emerge, where some are closer to being able to report on performance. There's a whole lot in the middle, and then there are some that are really straggling. And that shouldn't surprise us. I think that's how we'll probably see this play out. But the midpoint assessment is coming up, and that to me is kind of the break from reporting and being paid for process, for structure, for putting things in place, and shifting to pay for performance. So in that shift, we will really see kind of the rubber hit the road. We know that governance structure and those things are important, but we also know that this is all about deliverables, and it's all about achieving the long-term goals of DSRIP. So when we talked with the PPSs about presenting today, we asked them specifically to address a couple of key issues that, as well as bringing you up to date on where they are. The first was to really talk about not just their progress, but also some of the challenges that they're facing. How is this working? You know, the grand scheme of things, there are many things that can look great on paper, but don't work out in real life. And I think there's a lot of hope, expectation, commitment to making sure that this isn't one of those. But there will be challenges, and there will be setbacks. And I think the only way we can really learn how to do this better is by acknowledging those, talking about those, and helping everyone understand how you move past those barriers, rather than just say, well, we couldn't do it. It was too hard. because as John said, this is hard work. And this is a population that not only morally, ethically, equitably, but frankly, financially, is very, very important to the state of New York. And so the idea that these PPSs can be successful is going to take the work of all of us in this room to make it happen. The other thing that I think is really important and that we've asked them to talk about excuse me, is that DSRIP is about care transformation. It's not about 5 years of funding to do 11 projects, tick them off as done, and then go away. The seeds of the future have to be sown in this 5-year period. And having gone around and visited PPSs, too often I've heard, well, this is a 5-year grant, and we're going to do this stuff. And when you say, well, what's going to happen after 5 years? There's this kind of blank look like, well, we got all these people now. I guess they'll either go away or something else will happen. This is transformation. And that means this 5 years is only the beginning. So if a PPS is not investing in the long term now, they can't wait till year 4 Q2 or year 5 Q1 to begin to think about the long term. So we've asked them to really tell us how they're beginning to think about transformation and what will continue over time. The question is not whether the PPS will exist over time, but whether the work, the investments, the new workflows, the new relationships will continue over time. And so we'll hear some of that from them. Another important piece, I think, is this whole idea of community engagement. There's patient engagement and community engagement. If I hear any complaints about the PPSs in general, and I don't make these specific to these two, it's that they have not reached out sufficiently to those in the community who have been working with these populations for a very long time and could add value to the work of the PPS. Some of them are building their own staff, and we see duplication of work from what's been happening in the community is now being paid for and done by people in the PPS. That to me is an alarm bell when you talk about long-term sustainability and transformation. Others have very, very tiny staff and do all their work through community partners. So there's a wide variation among the PPSs, and I think we're very fortunate here that the PPSs agree to come and talk with you as a community every 6 months so that you can begin both to understand where they're at and build connections with each other. Another member of the oversight panel asked me yesterday, because he knew we were having this session, whether or not people would talk about, one of the things he's concerned about is what he calls the hub and spoke mentality. That the PPS is the hub, and they are building relationships one-off with different organizations, different sectors, but there's not enough work done on connecting those organizations with each other, so that it's very one-off from the PPS to this group, from the PPS to this group, but not enough attention being paid to getting those groups to begin to work together, which is also part of building the web that's going to be needed for long-term transformation. So just like you, I'm very interested in hearing from our colleagues today. We're very glad that you continue to be interested in this. We are the only region currently in the state where the PPSs report to the community every 6 months, but there is a lot more interest as word of this kind of activity has gone on. The premise for this that John Craik and I talked about was that the PPSs have an obligation not just to the state to use the money well, but to the community to use this for our long-term best interest. And we think this kind of presentation helps with that. If you have questions that aren't answered in the presentations, that's what the cards on the table are for. We will collect them, write them down as you think of the question, and we'll collect them and ask our panelists to address them after their presentations. So that's enough from me. I'm going to go to an airport bar while you guys are talking about this, and we're going to start with Amy. Amy White-Storfer from Community Partners of Western New York. Would you like to stand up so people can see you?
Hi.
No, I meant here.
Oh, sure.
Okay,
It's funny.
there you go.
Okay.
Have you got the clicker?
I do. I just want to check it, make sure. Where do you point it? Right at it. There we go. Okay. Good morning. So happy to see so many familiar faces here this morning. Again, I want to send Carlos's sincere apologies. As you know, duty calls, and with DSRIP, we're real used to being real flexible. So to echo what Ann says, we couldn't do the work that we're doing with transformation without all the partners in the room and the folks who are working with us every day. I feel like our PPS, specifically the community partners, is really relying on community partners as project leads, as really creating these business plans and these work efforts for the 5-year project and beyond. So I really relate to what you said, which is really relying on the community. For those of you who are unfamiliar with our PPS, I've put a little bit of an overview slide together, but I can talk a little bit off the slide because I feel like you can read the slide. But knowing a little bit about our PPS is the majority of our PPS is covered by the Catholic Health System and the Catholic Medical Partners Physician Network. However, we have a huge amount of connections and growth potential for collaboration in the Chautauqua region, which is sort of a growth area and an interesting area for us to be working with outside of what the Catholic system is really known for, which is Erie and Niagara. So, and I put that in the bullet right there in the middle of the slide there. Chautauqua County Health Network and WCA Hospital, as well as Westfield, are huge partners for us in the Chautauqua region. So, it's also important to note that the state calls us a small PPS, so they actually labeled us during the midpoint assessment as a small PPS, which means our patient attribution, but also the planned revenue intake for the project. So that also impacts us from an infrastructure perspective. Obviously, we have to respond to the same set of deliverables that the larger PPSs and the middle-sized PPSs have to. Some of those things really are not flexible. You can't reduce scope just because you're a smaller entity. You still have to comply with the requirements. Our team does a heck of a job doing that. And again, we rely heavily on community partners to assist us. We have great relationships with some key partners like P2 and rural AHEC and organizations like that to help us with some of those deliverables. It's important to note when you look at the Catholic Medical Partners Independent Physician Association, their partners have a history of population health management progress and have been doing it for some time. So luckily, our PPS is able to build on that knowledge and to tap into that knowledge. They've done it for their ACO, their Accountable Care Organization, as well as working with their physician network and the payers on incentives for outcomes improvement, of course process improvement, and of course healthier communities that they're managing. So just a little bit of an overview there. I like this slide, and I show it a lot. Those of you who come to our project advisory committee will be familiar with this slide. Essentially, it shows by the focus areas of the projects, all the projects that our PPS is involved with, by what our planned attribution or contact areas are. So you'll see patient counts by each project area. Including the IDS, which is, of course, the Integrated Delivery System, which is focused on how we have interoperable data across systems, how we work with the RIOs, how we work with the PCMH or advanced practice practices, and it also includes our governance and our work stream milestones that actually are somewhat resource intensive, like I said, like workforce and other types of cultural competency and health literacy initiatives, who are things that we have to deliver. Even we're in that small category, we still have to deliver to the scope and scale of the larger PPSs. I think it's important to pull out telemedicine and the maternal child health outcomes, which is our nurse family partnership program, as crossing into that primary care sort of community-centric projects, and then telemedicine being sort of ED hospital-centric. The reason that we threw telemedicine sort of into sort of a leg in both worlds, both the IDS and the community hospital relationship, is because our key partner on telemedicine is our a hospital partner in Jamestown WCA Hospital. So just to show you kind of a little bit about where our resources are going and why they're going in certain places, because of the attributions that are really where we think they're going to be touched the most for those patient populations. So one of the things is Anne had asked us to talk about is how are the funds being distributed? How are you connecting with community partners? Where is the money going? We always try to talk about this because, again, just as a reminder of all the different levels of DSRIP programming that have to be done for state requirements, but are also important for that integrated delivery and a population health management long-term roadmap. So we are supporting a lot of care management efforts that exist in the hospitals and in the practices already. Catholic Medical Partners is a very robust system already, so we are adding additional support so they can serve more of the Medicaid population. We are also supporting both in Chautauqua, Erie, and Niagara, converting practices to the appropriate level of PCMH. Patient-centered medical home is the chosen model for our PPS. We are always looking at advanced practice care. The state guidelines for that continue to evolve. I don't think that those timelines are going to line up with what we need to accomplish for PCMH. However, we have it in our back pocket. The advanced practice model is certainly something our teams are looking at. We have a huge technical team at Catholic Health who's both supporting our practices who are involved in the CHS and CMP practices, but also supporting Chautauqua area. We are also working with technical teams at CCHN and WCA Hospital. Our technical team is significant. It's a resource-intensive effort. It requires, there's a vendor that we had to engage with to be able to consume state-provided data because there are very strict security requirements. I'm sure any of you who run not-for-profits and touch PHI specifically are very aware of the info security requirements that are needed to consume that data. Know that that's a very labor-intensive, resource-intensive process, and the state has a very specific protocol they're looking for us to follow, and that's been something that's taken our technical teams and taken some resources to complete. We also have our workforce requirements, which we're really excited about working with Rural AHAC. They've been a great partner. We work closely with Millennium on this. One of the things I promised you last time we spoke was that I wasn't going to hit you with surveys and then have Al and his team hit you with surveys. I think Al, his team, Michelle Mercer, and I and our team have really worked together to try to avoid that for you. So where there's opportunities to collaborate, we do, and workforce is one of those excellent opportunities. And of course, cultural competency and health literacy, which is, you can't have DSRIP without having this, and I really a firm believer in this. For our PPS, we've really worked on a structural approach to looking at cultural competency and health literacy that deals with racial justice, economic inequality, and really talking about structural issues relating to cultural competency and health literacy, systemic and personal agency. And we're really proud of our work with the Community Health Worker Network, who's really helping us manage that and has some real on-the-ground experience to bring to that. Some of you have experienced their sample training that we did at our PAC meeting, and more of you are getting exposed to that as we reach out to you to do more cultural competency training. But I couldn't be prouder of that partnership with the Community Health Worker Network of Buffalo. Hello? Oh, there it goes. Okay, so I wanted to highlight a couple, and this is not meant to be a project update. This is meant to highlight some of our leadership that we've had in community-based organizations who've really stepped up to the plate on some of these initiatives. Because Anne had said, how are we working with community-based organizations? So I wanted to highlight a couple of the project areas they're working with us, and things like Community Health Worker Network working with us with cultural competency. So we have our Mercy Comprehensive Care over near the Perry projects. They're working closely with our partners at the Urban League to coordinate additional care management efforts and social work efforts, and able to broaden that reach by using a community health worker model. And that's a wonderful partnership that continues to move along quite well. We're really proud of that collaboration, having Urban League actually working with our social workers and care management staff at Mercy Comprehensive Care. This is an example of like a prototyping pilot that we're hoping to replicate at our additional sites. So really excited about that. And then another excellent maternal health outcomes partnership that I wanted to feature was the maternal fetal medicine initiative. This will be a second leg of the telemedicine initiative. So it sort of hits two projects, both telemedicine and maternal health outcomes, where we're looking at a review of ultrasounds by a practice here in Erie County who can support a rural hospital who needs additional physicians to look at those ultrasounds and provide that level of review that they need to be compliant. So we're really excited about this, and it's a really neat initiative. Again, it hits two really great projects. So I wish Carlos was here because this is his baby, that maternal fetal medicine. literally and figuratively. So again, this is another big heart of DSRIP. You call cultural competency, health literacy a big heart of DSRIP, and population health. Heart of DSRIP is behavioral health work in a primary care practice, and primary care practice is working with behavioral health. Anne and I've talked about this, and I've talked to our team at Millennium that to say this continues to be a challenge for the Catholics specifically because we have Article 28 freestanding health clinics, and there's Article 31 coming in and performing those services in Article 28 have implications for the hospital setting. So we continue to work out that regulatory concerns and to work with the state on that and to advocate on some regulatory relief there. But we continue to move forward, and I say that because you have to be flexible with these projects. I think we all dreamed that we would have behavioral health providers being able to see patients in a primary care setting and to actually bill for those services and have a sustainable business model. But what I think we're looking at right now to keep this project moving forward with some regulatory concern, I don't want to call it uncertainty, but concern, that we are supporting care management effort and getting that behavioral health team in those practices, those Article 28 freestandings, and getting them working with that care team and making sure that they have access to behavioral health appointments, that the people may be meeting the provider they could see, and really providing that support to that primary care team. And that's really a really excellent collaboration between Horizon and Spectrum. We're working with our other partners. Additionally, this is a nice place where Millennium and Community Partners is collaborating. We continue to talk across project leads. We continue to talk across project administrators, look at how different processes and workflows are working and sharing budget samples and things like that across our PPSs. I can't say enough about the collaboration with Millennium on this. We focus on that warm transfer from the primary care setting to the behavioral health setting. You could potentially be meeting that provider because they're right there in the primary care setting. You know your appointment. You get a little bit of more familiarity with that behavioral health, and it's a support to those providers. I call it a foot and door strategy because we got to keep moving forward, right? Anne said this at the beginning. We got to keep moving forward, these speed and scale for these projects. So this is something that's keeping us moving forward, and the state has been great. Be creative. Give them care management support. Of course, the health homes always play into this too, because if we can get someone connected with a health home, if they have a chronic condition, perfect example of a recruitment into a health home too. This is a project unique to our PPS in this area, which is the Palliative Care Integration into Primary Care. This is a nice highlight of 3 big community partnerships, which is Hospice Buffalo, Chautauqua, and Niagara. This is a wonderful opportunity. Again, the lead is Hospice Buffalo. They've been working with the 2 other hospices. We meet as a group. Again, these are funds flowing directly to community-based organizations to lead these projects, help us report out to the state, and vet the requirements that the state's asking us to comply with. I think that this is a nice look at how an organization can lead and really change how primary care is looking at the issues that they're coming up with chronic pain management and chronic condition management and really, end-of-life issues. Certainly there are obstacles for this particular project. We have our biases and things like that we bring to the table as providers around this discussion of end of life or chronic condition management. So that's one of the reasons that we're really proud to be working with Millennium and P2 on the Palliative Care Conference that's in mid-September. So really encourage your providers, even if you're not primary care, you want to come educate yourself on this. I think it's one of the most important things that's misunderstood in our integrated delivery systems, and I think that for this collaboration to have that opportunity to have that conference in the area, I really encourage you to participate as you're able. Our PPS is offering scholarships to folks in your community who may not be able to afford the registration. If you're interested in those scholarships, I'll wait over here after the conference. We also had sent out an email to most of the participants in our PAC meeting about that, but please see me and I'll get you information about the scholarships for that. And this is another really great Millennium, and it feels like most of the behavioral and mental health service agencies in the area collaborating together. This is our Domain 4 Public Health Education Initiative with destigmatizing mental health services, behavioral health services, and creating awareness of those services. In this, I think that this team is acutely aware to not duplicate effort of a lot of the substance abuse initiatives that are going on in the community right now. This team is very connected to the community. It's a shared project between us and Millennium. Again, this is direct fund flows to 15 different agencies in the community. One of the agencies that's really leading us is the Mental Health Association. Another one is ECPASA. We couldn't really, this is a really good highlight of, again, really propping up a long-term project, a long-term partnership that's sustained by DSRIP funds. So, I'll just go on to additional key. I mentioned WCA, continuing to work on telemedicine, our Chautauqua County Health Network partners. They report up to our key practices with the highest Medicaid threshold for that PCMH work. They also are helping us get patient engagement numbers reported out for certain interventions like care transition, cardiovascular disease management, the Palliative Care Project, behavioral health integration. CCHN also offers technical assistance, so we're supporting that as well. We also have 7 practices right now that are key Medicaid practices that encompass the majority of our Medicaid population down there, and they are getting paid to sign up for DSRIP and really be a part of DSRIP because they are not benefiting from that CMP infrastructure that's already in place. CMP, Catholic Medical Partners. All right, so this is just an overview of our revenue challenges, or I should say challenges, opportunities, our revenue opportunities. At the end of DY1, our PPS had the potential to earn $11,006,000 and was awarded 99.2% of that, which is kind of nice. It's on trend with where the rest of the PPSs are. They're all in the high 90s when they look at the revenue expected. So we actually were awarded $11,005,000. Okay. I want you to note though, for that number, $11,005,000 didn't come through the door. We got roughly $6.5 million our first year. Our PPS budget model was linked to outcomes measurement and attribution. So when we looked at this $11 million budget, which is good because we earned what we kind of thought we were going to earn, when we forecasted for the next year, it's similar forecast based on that attribution model I showed you on that that third slide, which is sort of getting those projects that have the highest opportunity to hit patients the greatest amount of money. But also we had the opportunity to learn from GNIHA, the Greater New York Hospital Association, on a model that they had developed which tied all the revenue streams to outcomes measurement, right? HEDIS outcomes measurement, things like, compliance with meds and, behavior, prenatal outcomes and things like that. So we were able to sort of play with a couple different ways to look at the budget. So when people say, well, why is this project getting a little bit more than this project? Or why does it seem like ED triage is getting all this attention? They have the most impact on our revenue, but they also have the most impact on outcomes. So know that it's driven by those sorts of decisions and those sorts of models. Very complex model. If anyone's interested in drilling down with it, I certainly welcome you to reach out to me because I'm happy to walk you through it. I also, bring a lot of coffee if you want to do that. And once our contracts are executed with our partners, and sometimes contracts execution takes a while, and I'm sure Al knows this as well, and I see my colleague Juan down there, that these contracts, they take a long time. There's a lot of discussion about the ins and outs of how we're going to implement and what's reportable and things like that. We do have a boilerplate contract that we use, but we attach an addendum which is very project requirement specific and budget specific. And my colleague at Urban League is working with me right now on one, and I know my colleagues at Catholic Charities I think I saw them walk in, are working on with us with one. But know that once they're executed, we flow funds immediately. So we get our invoices in and we start to get them paid immediately. So we don't like to see a delay in the funds going out the door. So we've been told that our funds are going out the door very quickly, which is nice. And our partners are feeling gratitude for that. We have a slightly different model than Millennium, so I won't speak to Millenniums, but just know that if you're in Millennium and with us and you see different models, I know that there are different models. I've come up with a new phrase I'll share with you is, you see one PPS, you've seen one PPS. Everybody's doing something different. So it's unusual if you're in multiple legs in different PPSs, and so I know that can be frustrating for you as partners, but it's because we have to have some flexibility based on things that we have infrastructure we already have in place or things that are our knowledge areas and areas of expertise. Oh, and the other thing I will point out on the first bullet is that equity programs, which is a huge part of our revenue stream, none of those funds for equity programs have come in yet as of the end of DY1. We started to see funds start to come in for equity programs, which pass through the payers, specifically in DY2. And this was just due to some contracts we had to put in place. Again, this was additional requirements on funding for equity programs, and it just added some complexity to the revenue flow. So this is a little pie chart. I won't, you kind of see where the money's going by project. And these slides, I'm sure, will be online afterwards, so I won't belabor the slide, but you get a sense of where they are. And then this one is an interesting one. By partner type, these are state partner types, okay? These are not our designated partner types. I don't want people to be misled by that orange pumpkin pie slice up there, because that actually, the state has Catholic Health System and CMP listed as community-based organizations in their category. So it's a legitimate funding stream because, again, we're supporting care management work and supporting practice outreach and PCMH efforts there, but it's not a true representation. For me, I see a lot of our case management, health home, the hospices, work that we're doing with practitioners as all being in that community-based healthcare setting. So it's a weird categorization, and we work with the state to sort of give them information when we see things miscategorized. At the end of March, we found a bunch of our providers. We had asked the state to consider recategorizing them. So yeah, it says like on a weird slide, but I wanted to be transparent in that and show you kind of where the money was going. So Anne had said, hey, if you missed that revenue, how are you changing what you're doing? Because it would be really great to hear how you're learning about, if you've had missed opportunities and things like that. So we were really focused on three project areas that were focused on patient engagement numbers. So patient engagement numbers are one area that we measure our projects and say, hey, are we hitting our targets that we put 2 years ago back in our application? So that's where our PPS has been missing dollars right now during the reporting period, which is missing patient engagement numbers. We've been really successful on our governance and sort of work stream deliverables and have gotten all of that revenue. So I'll focus on these areas so you can see what we're doing to improve those areas to sort of get missed revenue. So on our ED triage project, the challenges have been an evolving definition of what engagement was for this project, so that makes measurement difficult. But we developed our targets with health home referrals in mind, and our implementation plan was very heavy on health home referrals. That's really been, I would say, health home referrals count in this project if you already have an established relationship for the health home. They really want you to get people connected to primary care and have that and reestablish those relationships with primary care. So that definitely changed our targets, and sort of we know these are going to continue to be a challenge for us to hit these targets, these patient engagement targets. That being said, we are focusing on supporting a care management effort, and I want to highlight one application that we're using, which if you're involved with our PPS, you'll hear a little bit more about, which is the Crimson Care Management Module, which is a really nice workflow tool that helps the ED discharge staff and the patient navigator, the care management staff, the social worker, the outreach worker, customer service line who might be calling someone to connect them with primary care, all getting them communicating on the same centralized tool. It's a really neat initiative, and we're getting that stood up now with custom forms and custom ways for us to talk to our patients. It is population health management. It is a tool that helps us communicate across multidisciplinary teams. And if you're interested in more of that, I encourage you to come to our PAC. It's September 26th. If you want to know more about our PAC, you can use the contact form on our website, but we're going to drill a little bit more into that. We're doing a presentation to the state next week about our Crimson Care Management Module and talking about how we're using it for this project. I see this essentially as a key piece of our population health management strategy to get these multidisciplinary teams talking about it. Another benefit of this is that it gives us analytics, right? So this tool has been stood up for our care management teams at CMP, not specific to the ED, but just in general, since April, and they started collecting data. They've already started to see the high utilizers come out of this. So, example, a 39-year-old man coming into the ED for like 35 times since May. So those things are starting to come out, and although those analytics were available, now they're all in one spot, and people can talk across a care team about those individuals. On telemedicine, we have essentially three initiatives. We have the continuing initiative, which is a challenging initiative only because it's an outsourced initiative. This is specialist on-call vendor. We are looking at, this has been the one that's been doing the majority of the patient engagement reporting. We've had challenges credentialing because they're out of area and they have to credential with the hospital. Again, that's at maternal fetal medicine, so we're hoping to see more patient engagement numbers come in through that part of the project. And then we're working on another initiative that would be assisting the DD, developmentally disabled population, and helping them have some evaluation before they're brought to the ED. And there are certain regulatory concerns around this, but we're looking at this as an opportunity for a new program design. So that's addressing some of our telemedicine shortfalls as far as patient engagement. And then palliative care, again, palliative care had very aggressive patient engagement numbers. This team is working really, really, really hard, talking and problem solving and using that rapid cycle evaluation process to look at changing workflows. But they are hoping to see increased referral volume. Noticeable difference in referral volume. Teams are creating weekly embedded schedules at high volume practices. So the predictability of knowing when those care teams can talk to each other is going to help us with that. Hospice Buffalo's piloting a tool for Meta and EMR to get embedded to identify patients appropriate. So a tool that helps pull out patients that could potentially be involved in having that conversation and having the family there. Additionally, we're going out to fellow PPSs to share best practice. So this is an opportunity for us to go beyond just Erie Niagara and our talking to Millennium, but going out to other organizations that are doing these palliative care initiatives and looking at things that potentially could count as additional engagements. Rather than a sit-down consult, are there other things that we could be counting as engagement for this project? So these are the things that we could be counting potentially, but we really want to get our ducks in a row and make sure we have a good workflow process documented before we try to count that for patient engagement. I think this is an example of sort of an evolving project design, challenges, because the state kind of probably had in their mind what they thought they wanted, and the federal government kind of probably had an idea of what they've seen work in the past. But we're all interpreting this together, and people who are on the ground working with these patients dealing with chronic conditions and pain management and end of life, those families are bringing in the experience, and people have been doing it for a very long time, and the state doesn't try to challenge those folks at all. They're really relying on them to help make this program design work. So I think that's kudos to the state leadership on that. Great. So I'll just say, lessons learned, focus on community strengths. I think to that you heard that in every part of my presentation today. I think create a structure that supports unplanned requests from the state. The midpoint assessment had a lot of work associated with it, and we spent a lot of time on the midpoint assessment. Those of you who were with surveys got surveys in the mail. I thank you for filling those out. There's a medical records review process for HEDIS outcomes for us that's involving our staff, and our reporting tools seem to be changing a lot. So these are tactical challenges. Be strategic in reporting to provider partners. Provider partners are getting hit they're getting hit from Medicare, they're getting hit from us, they're getting hit from the payers. Be strategic in your communications with providers. Try to understand their communication fatigue and support, especially primary care. Be flexible in your revenue and your budget modeling. Payment methods will change and timings will change for this. Luckily, none of our partners, I think, have felt this because we've had conservative budgeting. So we're not planning for money to go out the door that we don't already have in place. But no, we have to be very flexible here. For program design, prototype, and pilot, be flexible. I think everybody knows this. You heard that as a thread throughout my presentation. Looking ahead, managing beyond the 5-year. Establish data interoperability, right? Make sure people of different disciplines can talk to each other. Use the resources in the community to do that. Create a seamless delivery of services, both medical and non-medical. Patient medical record can be viewed by care team at any location at provider discretion. Social determinants of health included in the medical record or in an outside system, potentially. Social programs available in real time to address barriers to health. This is the ideal, right? We're hopefully going to take a big chunk out of this deliverable and try to get there. I know that we talk very closely with our colleagues at Millennium, and I know this is part of their roadmap as well. Outcomes measures are reviewed by practice teams in collaboration with key community entities. And I mean outcomes measures like those HEDIS outcomes and things. I think the practices are familiar, but we got to get everybody familiar with those outcomes. Community partners, people who are non-medical services, they have to understand how they can build a business plan around those models, those outcomes that mean something to the providers and to the payers. This informs the value-based purchasing and future negotiations that have to happen. we all have to understand those outcomes. Support PCMH or APC when we get our ducks in a row on APC at the state level. Health, home, and hospital-based care management through data collection, community-based outreach, and a robust referral network. Make the primary care system stronger with consumer-driven qualities. Focus on delivering care at convenient locations with technologies to support quality outcomes and improve communication. And I would say primary care system change has to be informed by analytics, and that's one of the reasons population health management is important. Population health management helps with the payment side, but it also helps with the strategic planning side and the planning for what do we need from the provider community. And of course, the community-based organization community. We will leave a legacy of culturally competent care and training, will continue. We're not going to just, do inoculations of cultural competency and health literacy and expect that everyone's going to be. We hopefully will build a system that will be supported long-term for cultural competency training and support. And it's the last bullet, but it's probably the most important, and Anne touched on it in her introduction. Establish lasting community partnership. Put the people together in the room talking across multiple interest areas and get them working together and give them that startup funds to do it. And that's the legacy, I think, 'cause that's the strongest for us at DSRIP. So that ends my presentation. I'm looking forward to hearing Al's and Tony's presentation and getting questions.
Thank you very much.
You're welcome.
Al, are you going to start?
Yeah, sure.
Okay, yeah. We have to change the... Hold on.
All right. Good morning, everyone. I'm Al Hammonds, Executive Director from Millennium Collaborative Care. As Amy said, we work really close with community partners on a lot of our projects. A year ago today, we were kind of working together, but it was a little tense, and I feel like today, after, being at this for almost a year and a half, we do work really closely together. Dr. Billatier is also a practicing physician. If this presentation had happened on a Saturday, he might be working in the ECMC emergency room. So he does that, works quite a bit and spends a lot of his time in the emergency department at ECMC. And it's really beneficial to our team because he brings real life, real time experiences back to the team where we can really see how our work needs to affect the community. So I wanted to mention that. I wanted to, like I said, both myself and Dr. Billatier will be presenting. And what I'm going to be talking about is we really build a sustainable process of driving change in healthcare in Western New York from the community up. I'm going to be talking a lot about lessons learned. I'm also going to be talking about sustainability and then from a financial perspective, how we're doing on funding and how we're flowing funds. Dr. Billatier is going to pick up the baton. He's going to continue talking about sustainability, but he's really going to talk about keys to success. And as a physician, he's driving that leadership from a physician perspective.
For years, there has been a call for better coordinated healthcare for patients. And now, change is happening. Under the leadership of Governor Andrew Cuomo, New York State has launched a 5-year plan to create a better healthcare system across the state. The good news is that across 8 Western New York counties, a collaborative of healthcare providers, physicians, and community organizations are actively engaged in transforming the delivery of healthcare to the Medicaid community. The focus is on increasing efficiency and value and connecting each patient to the quality healthcare that is needed at the right time. How are we making this happen?
It takes a dedicated and experienced team of healthcare experts to look at how each part of the healthcare delivery system touches the lives of our Medicaid patients.
That team is Millennium Collaborative Care, a performing provider system whose lead entity is the Erie County Medical Center.
Our mission starts with a common belief that all patients deserve quality health care. The role of the Millennium team is to collaborate with our healthcare partners.
Together, we're working to increase evidence-based best practices that will continue to improve the health and wellness of our Medicaid patients.
We take this task seriously. Research has shown that opportunities exist system-wide to improve patient care through increased collaboration, clinical integration, and implementation of new ways of coaching and treating patients.
So, change is underway, with a statewide goal of reducing avoidable hospital use by 25% over 5 years.
We are observing and sharing information about what parts of our current healthcare system works and implementing a plan based on best practices. We are focused on 5 project areas: ambulatory services, behavioral health, community engagement, acute care, post-acute care.
We are improving the coordination of care for each patient by working with primary care practices along with key clinical and community-based partners across Western New York.
We are improving behavioral health care delivery to high-risk patients by working with partner agencies across 8 counties with a focus on sharing critical patient information.
We are empowering diverse communities by engaging community partners through activities, resources, and linkages to improve health outcomes.
We are creating a medical patient care plan beyond the emergency room by working to assist the hospital emergency teams with connecting patients with the best healthcare provider to continue their medical treatment.
We are decreasing rates of hospitalization among patients in skilled nursing facilities and in home care by implementing standard protocols of care.
Yes, change is happening. Healthcare change that will impact generations. Follow the progress at this website.
All right, we put together that video because we felt like with everything that's going on in the community, we needed to succinctly, in a very easy way for the community to understand what's really going on and how we're going about our work. So hopefully that was helpful to you. We're 273 days, come September 30th. I can't believe it, already we're about 1.5 years into DSRIP. A year from now, we'll be halfway through the whole initiative. So there's a lot of work to be done. Today, really want to focus the next few slides on some of the lessons learned that we've had and also some of the challenges. One of the things we felt that we needed was we needed to put together a vision for our organization and a mission statement. There's so many challenges coming at us from the community, and we have this much money being flowed to the community. We have to make sure that we're focused, that we don't get distracted, and we make sure that whatever funding and whatever efforts and whatever resources that we're using fits our mission and our vision of what we need to get accomplished. Streamlining governance was a big thing that we learned, lessons learned in DSRIP Year 1. We've got a really active and engaged board of directors or board of managers. Ann Constantino is our board chair, CEO of Horizon Health Services. Allegra Jaros is our vice chair. She is senior vice president in the Kaleida Health System and oversees, and I believe she's president of Kaleida of Women's and Children's Hospital. But we have a very diverse board, a lot of healthy discussion. So we've had to streamline a lot of our governance. We had 13 different committees, subcommittees, all part of the decision making for Millennium. What we've done is we've kind of consolidated down into 4 governing bodies. The ultimate decision making body is our board of managers. We have 18 people on our board of managers. But everything now flows up through these 4 primary governing bodies. We've combined the governance committee and the compliance committee. They're kind of like the watchdogs and the compass of how we're doing. And it's a combination, and from a compliance perspective, of ECMC oversight as the lead and the risk-bearing entity for our PPS, and governance, which is a very diverse across the 8 counties committee that really looks at our charters and making sure that we're having effective decision making. The physician steering committee is extremely active and vocal in terms of what we're trying to get accomplished. The finance committee, obviously, and then the clinical quality committee, which drives our performance from a metrics and measurables perspective. Our geographic councils and our advisory committees are extremely critical in the decision making and input of our work and how we get things done. Those advisory committees and geographic councils, like I say, now roll up underneath and get reviewed. Those minutes and the work of those committees rolls up into those governing bodies. We've got an upcoming community-based organization task force. Community-based organization task force is a significant committee within our PPS of how we get things done. Coming up on September 7th, we're having one of 2 retreats at our place over at on Kensington Avenue, and then there's a second one coming up on September 28th. Unfortunately, these aren't open to the general public. Community-based organizations that attested to Millennium Collaborative Care and have been involved in our governance process since the beginning are invited and will come. If you are not part of our community-based organization task force or not part of our system, please see me and let's try to get you connected so that your feedback and your input gets into this retreat through other organizations that may be present. In terms of sustainability, shifting gears a bit, a big part of our sustainability from an organizational standpoint is building the right team. We have about 35 total employees. We are pretty lean for the size of the work that we have to do and the size of our PPS. We have to have a diverse workforce, both culturally and experience and skills-wise. So we feel like we're building a great team of competent, capable individuals to help us drive this change for years to come. You saw in the video that we're taking a different approach. And this slide kind of is an introductory to taking a different approach. We started off in DSRIP looking at the 11 projects in a very prescriptive way. The work in the 11 projects still has to happen. There's a lot of deliverables, achievement values, and a lot of work that has to happen. But to really impact the community, we've broken ourselves up, like you saw in the video, into 5 clinically integrated buckets. So the 4 clinically integrated buckets on the left, acute care, post-acute care, ambulatory services, and behavioral health, is how we're driving the work. There's a lot of activities and engagement happening there. But community engagement is an integral part of all of those, and it has to be interwoven into all of that work in clinical integration. So just to go through a few slides of sustainability and what we're doing, we're igniting change through our community-based organizations, our maternal child health project work and initiative work. Since November of 2015, we've enrolled over 500 mothers and expected mothers into our community health network home and visiting program. It's really comprehensive, and we've gotten a lot of great traction here. One of the highlights of what we've been able to get accomplished so far. We're driving change and sustainability through our faith-based organizations. The Million Hearts Program, the Cardiovascular Disease Project, we're working that through the Million Hearts, working with the Greater Buffalo United Church Ministries. We're very involved with clergy in the community to be able to touch as many people in the population as we can. To date, over 222 participants have participated in screenings held at 7 churches and 1 community event, and we were recognized on Time Warner Cable as a impactful event in the community. We're impacting change and igniting change through working with law enforcement. On August 18th, we had a community day to try to reach out and making sure that we're engaged with the community through law enforcement, getting into the communities that way. Our PAM project, our Patient Activation Measures project, the infamous 11th project, significant impact so far. 15,000 recipients have participated in our Patient Activations Measure process. And these folks really, we're addressing a lot of the social determinants of health through this with homelessness, with transportation. This is how we're touching this population. We're igniting change and building sustainability through working with the county government agencies. This is a mental health awareness type event that we had. Community Partners was there with us. We did it. They participated, and we're making sure that we're closing the loop. We're connecting all of the dots to make sure that we're not duplicating work, that we're working extremely collaboratively to impact the behavioral health community. In Western New York, the behavioral health needs are significant, so we have to work together. We're igniting change through the county mental health organizations. This is more of the work that we've done in the Southern Tier, and you can see Allegheny County and even some in Chautauqua County, there's significant impact and work is being done there. I want to shift gears and talk a little bit about funds flow now and how is the money being spent, because we are igniting change and driving sustainability through funds flow. We've also had some lessons learned here. We have $3 million in direct contracts with community-based providers and community-based organizations. That a portion of that $3 million has funded 78 community health workers. So Millennium is responsible for funding jobs and funding work in the community for 78 different community health workers. These folks are out building the beginning stages of care transitions, continuity of care, communication, getting people connected to primary care. This is significant work. It's a heavy lift. A lot of our work in DSRIP Year 2 will be focused on engaging these 78 folks and making sure that they're effective. We look at ourselves and pride ourselves on working behind the scenes, working through our organizations. So a lot of people don't know that Millennium's behind the scenes funding these workers because they all work for different organizations in the community. We've got money flowing through our master participation agreements and contracts, and we flow money exclusively through safety net providers. $10 million was flowed to safety net healthcare providers in DSRIP Year 1, and $12 million will be flowing and is in the process of getting into contracts in DSRIP Year 2. We have to accomplish all of our deliverables through our partners. There's a couple of different models that different PPSs are adopting. Our model is to, have a relatively lean but competent staff and flow as many funds into the community as we can to get the work done. It's a risky proposition because we're relying on our partners who have extremely hectic schedules and demands on their plate, but we have to be able to drive change and transformation on the front line. So in DSRIP Year 1, we flowed $10 million to 47 different entities, which rolls up to about 31 parent organizations. In DSRIP Year 2, we're flowing money to 120 different entities, which probably rolls up into 79 or 80 different organizations. We're trying to get as much money into these community-based safety net providers as possible. You can see the bar chart to see where is the money going and how we're trying to gain traction and making sure that we drive transformation at the provider level. Talking about sustainability with DSRIP funding versus our Millennium budget, publicly we were awarded $243 million, but when you actually look under the hood and what we have to do to be good stewards of the money, 61% of the funds is all we feel comfortable in a conservative way of budgeting and spending, because the rest of that money is moderate risk or high risk. So $149 million out of that $243 million is what we feel that we need to make base changes and hit all of our deliverables. In the moderate risk payments, the $51.5 million, some of the things, there's equity performance funds that are there. That's actually in the red, in the unexpected payments in the $42.5 million. Not that we won't get any of that money, but it will be gravy money to help flow more money to the community. The equity infrastructure performance funds are primarily in the yellow. Those are type projects like our what we call our MAX series, our Medicaid Accelerated program through the state that looks at the super utilizers of the ED and really puts very comprehensive clinically integrated systems in place for a small population, and it's been extremely effective. Dr. Billatier has been the spearhead of that, and Janet Stuckel, who's here today, our clinical director, and we're making some significant progress in that yellow zone. But this is how we're spending our money and how we're distributing funds. Kind of to summarize my piece before passing the baton to Dr. Billatier, overall, our scorecard for DSRIP Year 1, we achieved 98% of all of our required deliverables. We had 591 achievement values and deliverables for DSRIP Year 1. That's a lot of stuff to do. I do want to talk about a significant challenge at the time. It's now we're trying to work ourselves through a bump in the road and move forward. Our cultural competency health literacy strategy was not accepted by the independent assessor in the third quarter of DSRIP year 1. Unfortunately, there were requirements around a comprehensive cultural competency health literacy strategy document. There were specific things that needed to be outlined in there. We missed the mark, and I take the blame for that as the leader of our organization. Our systems weren't crisp. We were so focused on a lot of different things, and this one fell through the cracks. It didn't get board approval in a timely fashion. So we're cleaning up our internal processes. We put irreversible corrective actions and processes in place to fix that. It was significant, and especially since we're so community minded. This is like at the heart of what we're trying to do. So it really hurt to miss this, but I feel like we're on the right track now. We got it fixed, and it's on track. The independent assessor has approved it as of the fourth quarter, and we're moving forward, and we're going to keep running. But I think it's important to understand, as Ann talked about challenges, that this is hard work, and it's significant work. It's complicated. It's the volume of work, keeping everybody on board, making sure you have all the proper decision-making channels in place. But there's no excuse for what we missed there. And that kind of a mistake at that size of level will not happen again. Not to say that we won't miss things, and we won't, but we're going to be very strategic. What we're doing with our board of managers is we've identified high-risk, high-performance deliverables in our AVs, and we're presenting that and making sure that it gets in front of the board so they can help us manage these things ahead of time. But in the end, we did still accomplish 98% overall and 98% of the funds flow that we were able to accomplish. So at this time, to continue talking about sustainability and increasing change, and to talk about key success, I want to bring up our Chief Medical Officer, Dr. Tony Billatier.
Good morning, everybody. Great to see so many of you keep coming back to this. Your partnership and your engagement is critical, and hopefully that'll become even more obvious as I talk about what I want to talk about here. And as Al mentioned, I'm going to talk about the keys to success. I go out and I talk to people who haven't heard much about us, and in terms of here's our 11 projects, and by the end of it, their eyes are glazed over, and I know what they're thinking. They don't ask it, but they're thinking, you guys are out of your mind. People have tried to fix healthcare forever, and all of a sudden now you're going to fix it. What gives? So I want to talk about why I think we're going to be successful. And when I say we, I mean us. It's not Millennium per se. We're the facilitators, we're the igniters, but the work really is done by our partners. We're not a healthcare delivery system. We're not a social service delivery system. You're that, and that's why your participation and your engagement is critical. And let me just tell you that my concept, and I think a lot of us back at Millennium think in terms of these 4 changes that we have to make. We have to change the delivery system, and that's in large part what the 11 projects are about. But if all we do are the 11 projects, we're not really going to hit the mark. We're going to go home at year 6, and we won't have made all the changes we need to change. So we need to go beyond those, and we need to transform the system even more. And we're doing stuff like that, as Al mentioned. We're doing this MAX series, and if we have time during the Q&A, we can talk about that because that's very interesting. And we're doing this through our master participation agreements with our partners. We're flowing funds to them, and they're going out and making these changes and getting these 11 projects done. We need to change the payment system. And this is going to happen with or without us. And this is not a Medicaid-specific issue or a DSRIP-specific. This is about where healthcare reimbursement's going in America. It's going from when the patient walks in, I take care of them, I send a bill, the patient walks out, I'm done taking care of them. Now they're back out in the community. 2, no, you're responsible for them 24/7. And so here's a pot of money, take care of them 24/7, and figure out how to do it. And so that's really what this value-based payment thing is all about. So it's moving from taking care of individual patients while they're physically, in your office, in your clinic, in your emergency department or nursing home or wherever, to they're everywhere in the community. And even the sickest of patients, if you think about it, spends most of their time in the community. And so that's really where health and wellness happens. And that's not where we are, that's where many of you are. And so that's where we got to hit the ball out of the park. We got to figure out how to engage you and make this a seamless system so health and wellness continues well beyond into the community. And then we have to change probably even two harder things. We have to change doctor and provider behavior, and we have to change patient behavior. And I'll submit that if we don't do all four of these things, we're not going to do this. We're not going to be successful. And so, the doctor behavior, that comes through education. It comes through motivation. People always say, well, we need to educate. Well, we do, but a lot of times both doctors and patients know the right things to do. They're just not motivated to do it. And so we got to figure out how to motivate people. Now, on the provider end, that's in part what we're doing through our MPAs, our agreements. We provide metrics that the doctors and other healthcare providers and agencies have to hit. And if they hit them, we flow the funds to them. On the patient side, that's where we need to have your involvement. That's really where this is going to be the hardest one, I'm convinced. Getting people to do the right behaviors, the right health behaviors, and that's quite a challenge. And that's going to happen hopefully through care management and all the things that you do. As you can see here, we have quite a large population. You can't manage this large of a population without some sort of systemic approach. And so what I'd like to talk about now is our population health management. So in general, our keys to success include managing populations now, and not just individual patients. They also need to include exploitation of health information, and that's in part the tool that we're going to use to help all of our providers and partners do that. And then finally, we need to figure out how to integrate care, and talk a little bit more about that in a minute. But this is our strategy for our data. And those of you who have had the pleasure of looking at charts and graphs from health information technology people, my eyes glaze over. So they dummied this down a bit to where I could understand it anyway. And let me try to explain that. Once upon a time there was paper, and every patient record was on a piece of paper, and that would work as long as the patient kept going back to the same provider who could pull the paper and look at, all right, what's your history? But as soon as a patient goes to a second provider, that doesn't work too well. Well, that evolved to providers had electronic medical records. That was still a standalone entity, so you still couldn't figure out what does it say in somebody else's record, but you could at least more easily search through your own records. That was an advancement. But the next step was we got to start tying all these electronic records together. And so that's the role of HealthyLink, our RIO, or Regional Health Information Organization. And for those of you who haven't heard about HealthyLink recently, it's not your grandmother's RIO anymore. And if anybody's interested, I'd love to come out and talk to you more about the ways in which you can exploit the use of that. But now the RIOs, and HealthyLink in particular, really are designed to help you take care of single patients. When the patient comes in, you can look through your records, and now you can fairly easily look through everybody else's records using HealthyLink. But what you can't do is look at, here's my patient panel, tell me all about all of them, and who's got high blood pressure, and who's got diabetes, who's not taking their medicines. That currently can't be done with HealthyLink. And so now what we've done is we've gone out and purchased a Cerner product called Healthy Intent that layers over all of this. And now this is a tool for us and for our partners to be able to look at our entire populations and to be able to monitor them. There's various tools within it so we can risk stratify, for example. So we don't have enough resources. We, again, meaning you and us, don't have enough resources to take care of everybody. But the good news is that, the 80-20 rule is alive and well in healthcare. So we don't need to throw all of our resources at many of our patients. But they're the ones whom are high needs, we better figure out who they are, and we better target our limited resources at them. Healthy Intent will allow us to do that. As an example, there's built-in registries. So one of the things that we need for one of our projects is, tell me everybody who's got high blood pressure and is not treated. Wouldn't that be great to know? And then go out and find them and get them treated for their high blood pressure. This will allow us to do stuff like that. It'll allow us to report better. We have standard reporting, as you've heard, but it'll also allow us to do ad hoc reporting. And when we come up with all these questions, we can now do deep dives and we can do analytics. And that's where we got to go. Just a couple other points that just in terms of the data strategy, we're going to feed Healthy Intent directly from ECMC's electronic medical records, both their inpatient and outpatient, and we're going to feed it directly from Kaleidus and from Niagara Falls. The rest of the health information is going to flow from doctors' offices, from labs, from other hospitals, and so forth, through HealthyLink into Healthy Intent. And I also should mention that we need to go beyond this. We need to not just have patient health information. We need to know cost issues. So this database is also going to be fed by claims data. So now we can start matching up what's the health and the costs look like. And we've got to figure this stuff out. Now we got to go one step further. We've got to get a 360 view of patients. We've got to know about not just do they have high blood pressure, but oh yeah, they're homeless too. Or they're not eating right. Oh, they get Meals on Wheels, or they don't get Meals on Wheels. So we've got to also figure out, and HealthyLink is working with us very actively, trying to figure out how do we also bring in the social determinants of health information so we can have a 360 view of patients. And I'm telling you, once we build that doesn't exist anywhere that I know of. That will be extremely unique, extremely powerful, and we've got to get there, and we've got to get there quickly. The 23 million seconds that we're into this already have gone quickly, and the next 46 million or whatever we have left are going to go even faster, I think. So we're running a little short on time. Let me just make a comment here about some of the feeds into Healthy Intent. So one of the things that we need to exploit, again, is technology. Well, there's devices that people can have in their homes, remote patient monitoring, that will feed data automatically in the system. So take a patient with congestive heart failure. So one of the ways you know if a patient's getting worse with congestive heart failure is if their weight starts to go up. They start to retain fluid, their ankles get big, their weight goes up. Well, there are scales that are Bluetooth enabled that patients can step on every morning, and their weight goes into a central call center. And when their weight starts to go up, flags should go out. Somebody needs to go out and figure out what's going on. Aren't you taking your medicines? Or whatever is happening. So those are the things that we need to exploit, and that data's got to get fed into this. So let me just shift gears just a bit and talk about integration of the healthcare delivery system. So as you heard in our video, this is sort of how we think about it. Unfortunately, some of these boxes are missing, but let me just describe it a bit to you. So on the top is acute care. This is emergency departments, inpatient wards of hospitals, urgent care centers, and as you heard, Michelle has divided up her teams into these 4 areas, as well as the community care arena around them, which is again where many of you work. On the left then is ambulatory care. That includes primary care physicians and also specialists. And then on the right are behavioral health care partners. And you heard that the behavioral health care partners in the Western New York community are the same for both CP, WNY, and us. And so we're really working hand in hand on this because we can't drive them crazy of having to do it our way for us and they have it. That doesn't work. So we're working very closely with them. And by the way, this includes not just behavioral health, but also substance abuse providers, which obviously is has become a big problem. And then at the bottom are post-acute and long-term care. These include skilled nursing facilities, home care agencies, and the hospice organization. I can't say enough about end-of-life care. Our deliverables are all about 25% reduction of unnecessary hospital use. But if you think about it, this really is based on finances. We can't afford healthcare costs going into the future. And if you look at where we spend our dollars, we spend it at the end of life. And so we need to focus on that. We really do. And we do things to people who don't want things done to them. It's just we don't ask them up front, what do you want and what don't you want? And so let me also put a plea out that you encourage your networks to attend the P2 conference, because that's really what that is going to be all about. But now let me say this, that these 4 entities have become, unfortunately, individual isolated entities. There's very little integration between them, and we need to fix that, and we're starting to do that. So what needs to go between them? Well, first of all, patients do, and that's where they get lost. You know, in general, when a patient's in a doctor's office, when they're in a nursing home, wherever they are, they get pretty good care. Now, we need to improve it, but they get pretty good care. It's where after they leave that setting, that's where we lose them. And that's where our health system has, I think, fallen apart. You know, it used to be primary care doctors would call us in the emergency department before they sent patients in, and then we'd talk to them about their patient. They knew the patient had already called them. If the patient needed to be admitted, that doctor admitted them. There was a continuity of care. Those days are long gone, but we need to make that happen again. And so we need to figure out how to integrate better, this integrated delivery system. Part of that is better communication. So now there's things like HIPAA-compliant text messaging systems. We need to exploit that so we can talk to each other as providers. We also need to flow data in between these, and that's in part what the Healthy Link and our Healthy Intent is all about. And most importantly, we need to do warm handoffs, and we need to help people get between all of these things. That's where care management needs to come in. We've got to figure out how to exploit the care management. And so let me just very quickly, in the 2 minutes that I have left, talk about one of the entities. And when you talk about sustainability, who's gonna pay for care management? And I believe this probably is along with data sharing, probably one of the most important things that we can do going forward. We got to figure out how to do this coordination of care and warm handoffs and so forth. So health homes are part of that solution, but in terms of sustainability, health homes are independently funded by New York State. They get a PMPM for patients who are enrolled in it. Let me tell you that a challenge there, by the way, is that many patients, when asked, do you want to be in a health home, say no. So we got to figure that out. And part of the reason probably is because they have no idea what a health home is. And so what I want to do today as well is just very quickly share some information about health homes with you so you can help spread the word. First of all, these aren't places. These are service models. They're organizations. They're not necessarily healthcare deliverers. They also might have primary care attached to them, but they're not necessarily. And their goal in life is to navigate people, to help them get through the healthcare system, and to deal with both the medical stuff and, equally important, the social determinants of health stuff. We've got to bring this together. We think in terms of you didn't take your medicine. They're thinking in terms of I don't have a place to live. And so we've got to figure this stuff out. How would we work together to meet both of those needs? They're free to the patient, and they're, as you see, non-mandatory. But that again is an issue with some patients. Here's who's eligible. As you can see, anybody who's Medicaid eligible has to have 2 chronic conditions. Obesity is one of them. The bar is very low. Many Medicaid patients are eligible. And we really need to exploit this. We've got to start getting patients into health homes. And again, their mission is to meld their 2 worlds together and take care of the whole patient. And you could see here that these are people who are at risk and really should be looked at for health homes. And so who can refer them? The bottom line here is you can. Pretty much anybody can. Okay.
Let's leave them wanting more.
All right. Okay. So in 6 months we'll be back, and I will show you the rest of my slides. Okay. Thanks.
Sorry, Tony.
That's okay.
Yeah. Now, on your table are cards. If you have questions, hold them up, and someone will come by and pick them up. While we're waiting for your questions, and please, are people asking? Well, anyway, I always have some, so let me start with those. A part of this population that each of you are expected to serve are developmentally disabled, and I didn't hear anything in your presentations about how you're working with that population. And so maybe you want to start and just tell us about that.
Well, I think in general, like when we have folks identified, we're connecting them with, the appropriate provider, both in our care transition and our ED triage project. One of the projects I know that Carlos is working every day on is a connection with a developmentally disabled agency to help us with their process to make sure that their providers feel comfortable taking the patients to the ED or potentially getting a screening at the agency, the home agency itself. So that's actually a telemedicine initiative that's going to hopefully help those agencies keep their patients in the home appropriately. However, there's regulatory concern around that, and I know that the partners that we've been talking to at the developmentally disabled community have been talking about this neglect concern that the developmentally disabled agencies have really identified as this is the reason that's driving these patients to the ED. So we're hoping with this telemedicine evaluation solution, again, that's in program design right now, it's not finalized, the workflow, this will hopefully assist that concern and alleviate that concern. And I know Tony was involved in that working with Bridget, so I guess I'll defer to you and talk more about that.
Okay, very briefly, it's pretty clear that use of the emergency department by individuals with intellectual and developmental disabilities is higher from a percentage standpoint than individuals who don't have IDD. And so when you look at the root causes of that, a large part of it is because they're sent there, because if they're not sent there, individuals are sometimes accused of neglecting them. We've created this culture in America that goes beyond just this population, but the idea is if you haven't been to an emergency department, you haven't gotten the highest level of care you can. And we've got to overcome that. Anyway, Bridget and I actually drafted a white paper and sent it to OPWDD and also the state health department outlining this problem and asking them for some relief to try to change this culture. In the meantime, various techniques can be used, though, to actually give patients care in the community that is adequate and meets their needs and doesn't disrupt their lives and make them come to the emergency department. Telemedicine is one technique. Sending care providers actually into the community is another technique that People Inc., for example, is exploring, and we're working with them on that as well. So we've got to get our arms around this issue. And let me just tell you a 15-second story. I took care of an individual who had IDD, lived in a group home. He was made to come to the hospital because he had been out drinking and came home, and they said, our policy says you have to go. So they called the police and made him come. He said to me, I'm a 34-year-old man. I should be able to drink. And he was fine. I sent him home. I didn't get a CAT scan. But that's often what happens. And that's the truth. So we've got to stop this. And we're just making these people's life miserable. We can do better.
One more quick note on the developmentally disabled population. We are extremely, as a PPS, from a structural and process perspective, we're extremely integrated with them ever since the beginning. Bridget Bartolone is on our board of managers. She's a very vocal force in terms of making sure we don't forget. We've got 8 different developmentally disabled organizations that we flow funds to, DSRIP Year 1 and DSRIP Year 2. So I apologize that it didn't come out in the slides, but we're integrating a lot of those developmentally disabled, the developmentally disabled population. We're grouping a lot of those efforts with our behavioral health type efforts to make sure that we effectively take care of that population. So I feel very comfortable, and Dr. Billatier and Amy did a great job of also summarizing specifics.
Great. Both of you spoke about patient engagement, and it clearly plays a really important role in each of your programs, but I'm not sure that we all understand what does that mean, that a patient is coming to the doctor and therefore considered engaged? Is it some kind of chat at Spot Coffee that you have to have in order to demonstrate engagement? What is it?
It's funny that you said that, because I thought that after I looked at after I present, I'm using this phrase and it's probably getting away from me. In the purposes of DSRIP, it's a very tactical definition. However, for the purposes of the integration into the population health tools and getting them, involved in their healthcare, it's another definition. So let me start with the first one, which is project specific. In the context of my presentation, I was talking about things that count towards whether the project is progressing to its deliverables. So are the patients counting in the definition of engagement for that project? For example, in our palliative care integration, are they getting a palliative care consult in a primary care setting? And what qualifies for the consult? that's patient engagement. And the idea of population health, it's having them engaged in their healthcare, and it's all of those things that make them focused on their healthcare and understanding why they need to be seeing a primary care, have that relationship, know that that's their first point of contact. And I think that's probably the sort of softer definition, but I want to defer to Tony because I'm sure he has thoughts on this.
Well, yeah, let me just bring out the difference between hitting our metrics for the projects and transforming the system, and this is, I think, is a good example. So getting a doctor to go to his, patient to go to his or her doctor is putting a check in the metrics that we have to hit. I'm making this up, but for illustration purposes. But so that's gonna, that's gonna get us money flowed to us so we can flow to our partners. But the really important engagement is the coffee at Spot, because that's where health and wellness happens, right? So that's where the community health worker working for the health home or some other agency that care manages says, well, you got your prescription, the Healthy Intent sent me a notice that you haven't filled it. How come? What's the obstruction? Can we help you? So that's the important part, and that's what we got to figure out how to do that.
And is that what's being counted as, is that what we're looking for from you through these PPSs?
I think we're managing a population, to Tony's point, and how you manage that population is meeting people where they're at. So if they need care management support, if they need a community health worker knocking on their door, that could be the definition of engagement for that patient. Other patients are very capable and very compliant. So I think it's about meeting people where they're at.
Okay. Speaking of populations and people, what about those who don't speak English or are deaf, hard of hearing, or are blind, refugees, immigrants? How is the PPS heightening both access and true health improvement for those populations that exist across the region?
That's why we're funding organizations like Jericho Road, like the National Witness Project, and others at a rate of 78 community health workers in the community. It's a diverse group of people. It's a small army of folks that are culturally diverse, multilingual, reaching those populations to get them engaged in clinical integration in our process. So that's why, when I mentioned those 78 folks, that's a big deal. And they get training through us. It's institutionalized training. And we're at the beginning stages of making sure that they're fully equipped to handle all of the issues. But they're an integral part of our patient engagement as well, of getting people pulled in and filling in the links, as Dr. Billatier talked about in that one graph, the in-between the bucket silo of healthcare.
I would say we rely heavily on our community partners for that outreach as well. Our folks like Catholic Charities and Urban League, also our PCMH practices. They have need as part of their work to be culturally competent and to be sensitive to these and provide solutions for providing care to them. So continuing to monitor that they're doing that and providing them the support they need is another piece of this.
And if I could just mention two concrete things that are being done but need to be done more of. One is that community health workers are a great interpreter if you hire the right people, right? So the definition of community health worker is of and from the community. And so if they speak the language, first of all, they're going to be able to help interpret. More importantly, they're probably going to be more impactful with the individual who's going to say, hey, I trust that person. The other thing, in another world of mine, we're trying to drive down the cost of language lines. And so if anybody's interested in partnering, we're trying to get a better community rate for this. This other organization started at $4 a minute for language line interpretation, was able to drive the cost down to 99 cents a minute. We can probably do better if we partner as a community. So far we have partnerships with ECMC, Kaleida, or discussions, Horizons, Deaf Adult Services, Sharon Hansen's here. So we're having discussions, so the more group purchasing, the more economical we can get. It's not ideal to talk to a patient with two phones, but if that's all you got, it's better than nothing. But again, the cost is a huge challenge here.
Well, to me, that's a good example of how the reach of the PPS and the resources of the PPS can be used to look for collaborations that may not be directly on the page of what you have to deliver, but it leverages the reach and the stretch and the power of a PPS. One of the issues we did not talk much about, but there is some interest in this from the group, is this whole idea of workforce. if you're going to reduce hospitalizations by 25%, there's probably not going to be a need, or you have to find your savings, will be a lot in direct care costs within institutions. And so a lot of these jobs are going to, yet you're needing people in the community. Workforce is a top issue on all of the PPS's agenda, and I know you've done some surveys and some other things, so perhaps you could brief the group on what your take is on workforce right now, what you're trying to accomplish, and how you see that playing out down the line. So why don't we start with you, Al?
Okay. Yeah, it's a significant effort, is the whole workforce strategy, workforce development process. When you're trying to touch 258,000 Medicaid lives, there's a whole lot of providers out there providing care. We did do our workforce surveys and workforce salary data analysis required by the state. We've got 5 different bargaining units that are part of our workforce efforts. All of them are very engaged in helping guiding our behaviors and where we're going. The bottom line is the workforce is going to shift. It's going to shift from a heavy, kind of heavy RN, heavy, nurse-driven, physician-driven type model to more of a community health worker-driven, LPNs, licensed practical nurses, more people who can do more, that are more flexible. Job descriptions are going to change, so that's going to happen. A lot of this work has been studied, and we have analysis of work that's done in New York City. So that shift is going to happen. So we're trying to map out, we're working very closely with Rural AHAC. They are our workforce development partner vendor, and they're helping guide us down this path of mapping out, this is where we are in the current state, this is where we're headed. Everybody knows there's a shortage of physicians out there, especially primary care physicians. So we're all over it, and we're also trying to work with all the different unions, the bargaining units, to make sure we're on the right track and get their help as well.
I'd echo everything Al said. Additionally, I think in our original application, we had not anticipated bed reduction at our major hospitals, only because Catholic Health had been doing some of this integrated delivery before. That being said, I think I'll say that, one of the things that we're bringing to the fold is, where are the gaps in primary care in our network, and where can we be addressing that? And part of the data collection process of the population health tools we're standing up is to help us target where those providers need to be, and where that services need to be provided, either in that hospital-based setting or additional settings and additional support for those primary care practices that are seeing the Medicaid population.
And what about behavioral health providers? It's well known that we don't have a sufficient number when you achieve all of your goals of getting these folks into behavioral health and integrated. Mm-hmm. Do you see the PPS as having a role in workforce development on something as specific as behavioral health providers? How do you approach that?
From my perspective, and I've heard Dr. Billiteri say this before, is this really getting the people who are doing primary care and doing that more educated on what they can do as a primary care provider to essentially say, how can we be supporting mental and behavioral health in that setting? And really bringing, if there's a behavioral health shortage of providers, making sure they're used for the most in-need population first, then look at the workforce development.
Right. So, there's a theme here. There's a lot of themes that cross-cut all of this stuff. And one of the themes is everybody works to the scope of their practice. If they're licensed, then that's pretty defined. If they're unlicensed, then the scope of their training or their capabilities. And so, everybody is in some ways a behavioral health provider, including community health workers, right? So they can help patients with anxiety and so forth. But then as you go up the training level, if you will, and at this pyramid, it's the psychiatrist at the top. Psychiatrists in the future should only be seeing the sickest of the sickest, and everybody else needs to play their part, including, as Amy said, primary care. They need to treat all they can. Anxiety, depression, those are the big ones, but there's plenty of good evidence-based of how they can do it. We need to get them educated on doing that, and we have efforts in that arena. And so, it's about a division of labor, and again, everybody working to their scope of their practice. So let me just make another general comment, though, that especially in primary care, but throughout the healthcare system, Physicians are going to be leaders of the future. They're going to see some patients, but really what they're going to do is they're going to lead teams, and those teams are going to take care of patients. And so in the primary care office, it's going to be APPs, NPs, and PAs under physician leadership. In the specific world here for behavioral health, we get the question a lot of we can't bill for example, somebody with an MSW who's not registered or certified or whatever. So hopefully that issue goes away under the value-based payment model because here's your chunk of money. You don't have to have that level of person because you don't have to bill for it. You're already paid for it. So hopefully that sort of stuff is going to help with this challenge as well.
Just a little information for you. This is all aiming towards value-based payment, which is really about not paying for activity, but paying for outcomes and results, so that, as Tony said, you might get a pot of money to serve these 100 folks. And as long as you achieve certain deliverables, it doesn't matter how you spend your money within, and that's very new in New York State, which just has really relied a lot on transactional payments. The more you do, the more you get paid. So I think it's a big culture shift. Alluding to some of the barriers on working at the top of your practice and those things, you alluded in a very elegant way to some of the barriers that state and federal regulations are putting in place for the work you need to do, and in particular regulations that really hinder the ability to truly integrate behavioral and physical health. Mm-hmm. So without losing your job, I guess, or your source of money, could you talk more specifically about that?
I would just say, like, in our setting, in our PPS, and we have what are called Article 28 freestanding hospital-based clinics. When they have to make a modification of their services, that affects their billing, it affects their APCs, it affects their certificate of need. So in general, they have, those of you in the hospital, a risk-averse position. They have to, they're a protection position. So to put a behavioral health person in that setting with its own door, its own exit, those could have certificate of need concerns. Also, there's volume thresholds, right? So if you get beyond a volume threshold, then you need to apply for this co-license, which again affects the certificate of need of billing. The state is trying really hard to help us with this. However, we have committed as a PPS to move forward and to support that care management and that co-location, at least of the providers and the provider staff in the facility, to get those warm handoffs going, because we have a timeline here. So we're making incremental progress, and I can't say enough about our collaboration with Andre and the team at Millennium, because they really have had some great subject matter expertise. Our project champion, project lead, Bruce Nesbitt over at Spectrum, has really been advocating at the state level, almost doing advocacy work on behalf of these licensing and these concerns. I think Millennium may have a different position because they have FQHCs, and that's a lot easier from a regulatory perspective. Ours is unique only because it's the hospital-based system.
Is it a lot easier on this side of the table?
Probably not. Probably not.
Yeah, the grass is a little greener. But, we thought we had this issue licked, I guess, early on in the process. The state realized that the regulations were a challenge all across the map. So they put in place a way to ask for waivers when DOH, OMH, OPWDD, or OASIS were involved, and they all agreed if it's a regulation, we'll all get together, and if it makes sense and it's not a safety issue, we'll waive that regulation. And so early on in the first round of these waivers, they agreed to allow co-location of 28s, 31s, and 32s.
Those are various clinic types.
Right,
yes.
So 28s are hospitals, 31s are behavioral health, 32s are
substance abuse.
Okay. Mm-hmm. Anyway, so we thought that we're golden. Well, then I think CMS got involved, and it's like, well, but, so I'm not sure that we're quite able to use those just yet. I think there's still work being done on them. And then when you throw a private primary care provider in the loop who's not in Article 28, and they want to co-locate with a 31 or 32, then that just blows the system out of the water. So we've got a lot of hurdles to get over that we may not be able to solve locally. They need to be solved in Albany or in Washington. So, but we've got to get there. Again, the 23 million seconds is ticking. So.
Right, and I would say too, there's all good intent all around. Like, everybody's doing what they need to do. It's just a slow process.
Intentions take us just so far.
Right,
as
exactly.
those seconds tick on. advocacy is one way that the PPSs can voice their concerns over these. Another way, and a couple of you asked about education of the public at large about how healthcare is shifting, and education of physicians who do not take Medicaid or other providers who do not take Medicaid, and how this is going to spread to them. When we move into value-based purchasing, they're all going to be going into value-based purchasing. And then I'll add a third group in there, and those are the plans. How is this all working to educate the larger community, the provider community, and do the PPSs have any expectations from the state to have that public education role in what you do? Al?
It's our job as a PPS to drive that education process for the most part. That's what we're doing. A lot of the actual deliverables are being driven through the providers, but we're providing the infrastructure. We're using the funds to provide the infrastructure and the process to provide training and education. In the arena of value-based payment, we have a MCO, a managed care strategy to work with the payers. It's our job to help put together value-based payment pilots to help take our healthcare providers and our PPS, take the payers on the other hand. We work with resources from the state. We provide our value add is our Cerner Healthy Intent data analytics tool to help provide and bring those relationships together and to help train people and train the community. That video that we showed at the beginning is we're going to be doing more of that stuff. It's our job to make sure what is clinical integration, what does it look like, and to show people those things is extremely critical and effective, and I really feel like it's a big part of what the PPSs need to be doing.
Right, and I would say on the physician education side, we really hang our hat on PCMH, and PCMH being, that patient-centered care, that team approach in general, and making sure that we're checking in with our practices and that they're continuing to do those processes that they did and established when they got their recognition, and continuing to move them forward into the 2014 standard. And I think part of PCMH is you must engage the Medicaid population. You must see these patients, and that's what we really as a PPS from the provider side. Now on the community-based organization side and the community provider side, for us it's really about where are they bringing, what's the proposition as the business plan as far as impacting outcomes, right? What can you bring as far as values? So an organization like Urban League says we want to be engaged with a community health worker model that can support an outcome that you're looking at, and we want to get folks trained and work with you on that, and they come to us with this idea, and we see them as an important partner to build that capacity in the community. So that's another good example of the kind of education. So we try to make it tactical as much as possible to make it real from an implementation side.
And let me just comment that a couple issues. This question really, I think, gets at the heart of the 4 circles that I showed. It's patient behavior change and provider change. Education is a means to an end. It's all about changing behaviors. And so on the provider side, we're about to stand up a learning management system that hopefully will be user-friendly to our care providers, doctors, APPs, and other providers, so we can educate them there. But again, I'll go back to motivation. We need to educate, but we need to motivate somehow. Mm-hmm. And then same thing goes on the patient side. And really, if you think about it, it's about health literacy. And so patients need to know what's the right thing. So when I have a sore throat, what do I do? I don't know if any of you have tried to navigate the healthcare system, but somebody on the inside, I don't even know how to navigate it very well. So we got to educate them on health literacy and what's an emergency, what isn't, why is it important to take your medicines, and so forth.
Okay. Someone asked about working with parents in pediatric sites, and I know you talked about birth outcomes in one of your big programs. Do you see DSRIP moving into pediatric sites, or are you already there? And what engagement, if any, do you have with parents knowing how important the early development is for children?
Is that part of any of the work that you're doing through the PPS?
you want to start?
Yeah, sure. We have pediatric practice inside the Catholic Medical Partners. They have the advantage of being benefiting from our population health tools, our care management systems, and things like that. So they're already part of our network, and they're definitely a part of our PPS and those initiatives. So.
And are they focusing on working with parents?
I would say that, when you're looking at the PCMH model, yes, it's a team approach. Parents are part of it, and yes.
Okay. Anything specific here in Millennium?
Well, let me say that DSRIP is not adult-centric. It's about birth to death, and so the focus is on every age group. And so when you see acute care provider, we're talking about we're talking about pediatric emergency departments. When ambulatory, we're talking about pediatricians. So they're in the mix as well. And so if you think about it, again, if you want to talk dollars and cents, an impact made early on in someone's life could have a huge impact, throughout the next 70 years, both financially and quality of life. So that's really got to be part of it. It's important to not just know what we should be doing, but what we should be partnering or not doing. So what we don't want to do is duplicate what's done in early intervention and pre-K programs and those sorts of things. So we need to partner better with them, and they're on our to-do list, if you will. And let me just also say, though, that Millennium, again, is we're not a deliverer of services. We work with partners who do it. So we don't interface with parents, per se, but our partners do.
Right. And is that part of any one of your 11 projects, parent involvement?
Yes.
Someone said yes. Is it part of yours?
Yes, any of our outreach to the practices.
Okay.
Right. So we have a maternal child health effort that funds community health workers who are care navigating, and CPWY has a similar program. So we link up pregnant moms and for the next 2 years of the child's life. So they follow the mom through the birth and the child through the first 2 years, and help care navigate so to make sure the child goes to the pediatricians and gets his or her immunizations and so forth. And this is evidence-based, and it has long-standing benefits, including less juvenile delinquency and all sorts of stuff well beyond age 2 years of age. So this again speaks to the impact that you can have if you intervene early in some of these conditions. And again, we're not doing it, our partners are doing it. We're flowing funds to them to do this.
Same thing with us with the Nurse Family Partnership Program.
Right. Okay, we've got just a couple of technical questions. Let me raise those, and then we'll probably reach our time limit. Both of you, well, I know you did, Al, and I think you did too, talked about equity payments, and that involves in some way health plans.
Do you want me to take
and the
this
money
one?
flowing through them to you? Is that?
Yeah, I'm living
Can
this,
you
so I'm
talk
happy
about
to give
that?
the overview of
Please.
it. So there are two. There's equity performance and equity infrastructure. For our PPS, it's 40% of our revenue. A portion of that's going to be high risk because it's based on performance. Originally, those dollars were given to the PPSs with I would say limited detail about how the funds were going to be distributed. The assumption was made they were going to come through the state like the regular payments. Speaking to the architect of DSRIP, a gentleman named Jason Helgerson, who some of you have seen, he said it was always in the plans to flow these funds through the payers, which
was a surprise.
Kind of a surprise, yeah. So I think it's okay, I'll put my positive green hat on right now and tell you that I think it's a positive because the payers that are engaged in the outcomes measurement already know about value-based purchasing in the context of their fee-for-service or regular payment. Getting them dialoguing about the Medicaid and how Medicaid can be outcomes-based measurement is a good one. They're very familiar with this, so just continuing those dialogues. This equity program is giving us opportunities to have those dialogues. Take it from the perspective of the health plan, though, something like Fidelis, which has patients in all of the areas of New York. They're getting knocked on the door by 26 PPSs who need to negotiate equity contracts with them and value-based payment contracts. Equity for us is 4 sets of contracts, 4 sets of deliverables to the payers that will impact our ability to collect that revenue from them. For us, it's tied to health home outcomes, engagement with the RIO, involvement with other key elements of our projects. They essentially get additional reporting from us so we can get that revenue. The second part of it is a selected subset of the HEDIS outcomes measures that we are targeting no surprise, behavioral health outcomes and maternal health outcomes. And they'll be looking at those measurements. They'll be looking at the state outcomes measurements that are collected as part of DSRIP. So we have our own outcomes collection, not the payer's outcomes collection process, our own outcomes collection process the state leads. So that's the sort of new nuance of equity, is that these two funding streams are independently reported to the payers, independently measured by us to the payers, and the dialogues between us and the payers now, not us and DOH. So it's adding another layer of sort of stakeholder management to what we're doing as far as reporting and relationship building. But again, I'll see it as a positive because talking to the payers is a good thing. We've got the providers, the payers, and the patients, and the payers are an important piece of this. So,
thanks for that overview.
Yeah.
Al?
Very quickly, Amy did an amazing job explaining that. For us, thank you.
Yeah.
For us, if you remember the dollars graph that I showed,
The green, orange, and
yeah,
red.
the green, orange, and red. So for us, the yellow is the equity infrastructure performance, which is what Amy just described. And for us, in that yellow range are projects like the Medicaid Accelerated pilot program, the MAX series, focused at super utilizers in the emergency department. And we did earn some equity infrastructure dollars in DSRIP Year 1. So we are making traction there. It also includes capital spending around integrating primary care and behavioral health. So that's extremely critical. That's in that equity infrastructure, as well as work in the Rio and the Shiny, the IT connectivity with Healthy Link in that graph we showed. All that's in that yellow zone. And the red zone on the graph is more of the equity performance funds, and that's back to what Amy talked about in terms of the quality HEDIS measures. For us, controlling high blood pressure, hypertension, diabetes, those kinds of things, but also looking at high performance metrics. Is the state hitting their metrics? Okay, that's in that red zone. We can do our part, but the state overall isn't doing it. We're not going to earn those funds. Our metrics, one of the super high, what's considered super high risk, is follow-up with behavioral health appointment within 7 days after hospitalization. That's a great example. If we can show evidence and objective traction, making sure that when people are discharged from the hospital that they're connected to a behavioral health organization within 7 days, we get to earn that money. So those are those kinds of examples for us.
It's important to note, and I don't want to underplay this, is that Millennium and community partners got together with the plans, the 4 plans in the room and the 2 PPSs. That was a great meeting, right?
Yeah,
That was, and it was a discussion about these high performance EIP measures and to say, or EPP measures, and to say, can we collaborate together? So essentially, we have the same measures, and they are affecting behavioral health and maternal health outcomes. And I think it was a good conversation, and I think the payers are learning too. It's hard for them because they're obviously in the same position where they're getting hit with federal and state communication. But I think we have a good partnership, and we're talking together. So.
Okay. Lastly, someone asked about the timing of the DY2 payments and amended master participation agreements, and I'm going to pass on that right now because I would guess that's a different question for Millennium and for community partners. So I would encourage whoever asked that to approach whomever it is that you wanted. I also got a question about ECMC medical records. I don't know if that's something you guys can respond to,
Yes.
or if that's an ECMC question, that they're not available online.
We could.
And if you can respond to that, that would be important to at least one person in the room.
Okay.
All right?
Yeah. Just a short answer. If you look at Healthy Link's website, you can see what hospitals and what labs and so forth contribute data. There's a good grid. Actually, ECMC is in Niagara Falls are the only 2 emergency departments that contribute their ED records, which is critical for primary care to see what happened. But we're working on getting all the other providers. So, for example, Sorian is teeing up the ability to do that through the Catholic hospitals. So that's a good place where you could see what's available online, the Healthy Link website.
Is there a plan, a time? I mean, is there a time period that most things will be on there?
I don't know that much about the plan because this is Healthy Link's initiative. But the timeline, to be honest with you, is often dependent on the provider. How quickly are they willing to share? But even more critically upon their EMR vendor, because the EMR vendors have to hook it up, and very often they're not very responsive to Healthy Link, let's say, and there's a cost often. So
Well, I think that question was specific to ECMC, and they can probably talk to you offline if they want that. Those were all your questions. I think, let me check if I got mine answered. I wanted to just understand, when you talk about the governance of Millennium and that you have a board of managers, are you a separate 501c3 from ECMC? Are you under the governance of ECMC? How is that structured? I know that yours is integrated into Catholic Medical Partners, but could you just explain to folks, are you an independent entity, or does your board of managers report to the board of directors of ECMC?
So our board of managers, it's 18 people that are community-based providers, and all of the decision-making of the PPS happens at that board of managers level. ECMC's role as the PPS lead is to act as a risk-bearing oversight organization to help guide the PPS, make sure we have the proper infrastructure, the proper support. So what I do is I report directly to, I have two reporting relationships as executive director for Millennium Collaborative Care. I report to the 18-person board of managers, and I report to the CEO of ECMC, Tom Kratolci. I sit and participate on the ECMC board of directors, providing DSRIP updates so that they understand primarily risk-bearing activities and making sure that we're on track and being good stewards of the community work that needs to be happen from an ECMC's perspective. But in terms of the day-to-day, week-to-week implementation of what we've got to get done in terms of the deliverables, that's the board of managers. And ECMC has done a good job of making sure that they separate the two. So I serve in those capacities on a structure. We are a DBA, doing business as entity of ECMC. We're not a 501c3, we're not a not-for-profit, we're an extension of ECMC in the community. We do have a lot of independence in how we do work.
That's very clear, Al. Thank you for that. And why don't you join me in thanking the two PPSs for their update. We've talked about every 6 months getting together, but I think what we would like to do in the future, and that's why this is a little more than 6 months after the last one, is have these sessions after the PPSs have submitted their reports, gotten approved, know where they stand financially in terms of the revenue, and rather than just automatically 6 months later where there's no real news.
Midpoint assessment's
the midpoint assessment is coming up, which will be a significant thing for the PPSs. And we will schedule a session to coincide with the completion of the midpoint assessment so that you know exactly where they stand. Is that okay with you? Okay, good. Well, we will see you all then
one more thing, please.
Sure, John.
And Ann's absolutely going to hate me for this, but it dawned on me sitting in the audience that in 6 months from now or after the midpoint assessments are over, and Ann's going to be angry, Ann will not be the president and CEO of the Health Foundation for Western and Central New York. She will be retired. So if I know Ann the way I think I do, I'm reasonably sure that instead of sitting up here, she'll be sitting down there, and she'll probably be going through her stack of index cards with a lot of absolutely insightful, probing questions that we should all ask. So Ann is not one for a lot of attention, but it's kind of a big moment, and it would be inelegant to let it go by without thanking Ann for her visionary leadership, her collaborative leadership, and just everything she's done for this community. So thank you, Ann.
Oh, John, thank you very much. Thank you very much. I'm going to miss this kind of thing. Maybe I'll finagle a way to get up here at the table, John. But thank you. I'm staying in town. I consider myself refiring rather than retiring. And so you will see some more of me. But thank you for that recognition. It's been an absolute pleasure. So it's great. Okay. Have a good day, everyone.
You're staying on the